Well, hi everyone, and welcome back to Cardiovisual Health Talks. My name is Tom Blevins at Texas Diabetes and Endocrinology in Austin, Texas. I'm very thrilled to be part of today's event with Dr. Ralph DeFronzo and Dr. Bob Chilton. And we're going to talk about the deadly connection between diabetes and cardiovascular disease. What every clinician needs to know: should cardiologists care about SGLT2 meds or GLP-1 meds? And of course, SGLT2s are like empagliflozin, mechanigliflozin, dapagliflozin. And GLP-1 would be the semaglutide, dulaglutide, and the other SGLT2 and the other GLP-1 meds. But should they care about these medicines, since these are glucose-lowering medicines? Why would the cardiologist care about glucose-lowering medicines?
Ralph, what do you think?
Yeah, well, I invented the SGLT2 inhibitors, and I invented them for lowering glucose. But I can tell you in 1993, when I went to Bristol-Myers Squibb, I also told them, based on the Brenner hypothesis, this would save your kidneys, okay? But who would have known that these drugs were going to have such powerful effects in cardiovascular protection? If I actually had to do it all over, I would have invented this as a drug for the cardiologist, because you can't make a person hypoglycemic. When your glucose gets to normal and it tries to drop below normal, your liver now kicks in and starts making glucose and won't let your fasting glucose go below 80. So this is a wonderful drug for the cardiologist. It's a wonderful drug for nephrologists. So what percentage of cardiology people are using these drugs now?
Well, what the report to me is around 6%. And the problem is that if you wait, like Ralph and I were talking, you may be somebody that didn't do well. These drugs are wonderful drugs, and they're so simple. You just take one pill. That's it. I mean, for the cardiology guy, you can't get any simpler than that. It's not even dose adjustment. Just take one dose, and it will take care of most of the problems. And two, it decreases cardiovascular death. It helps people that have heart failure with reduced EFs. We've already got those studies completed. And we've done this, I guess, Ralph and I have worked on for over 10 years. So this is not new to us, but to many cardiologists in private practice, this could be a life-saving drug to many people. And it has an NNT that is as good or better than a statin. When you think a statin trial is 5 years long, these trials can do it the same number in 3 years or 4 years for many of these trials.
And I would echo the same comments for the GLP-1 receptor agonist. Now, from the realistic standpoint, I can see a cardiologist giving a tablet. There's no reason not to give a tablet. I think it's going to be a little bit of work to get cardiologists to give an injection. And what's most disturbing to me is that half of endocrinologists, now leave the cardiologist out, half of endocrinologists don't use GLP-1 receptor agonists. They write very few prescriptions. So that's saying even within the endocrine field, we don't use it a lot. Now, Tom, you're an endocrinologist. You're up there in Austin, okay? Now, do you see the same problem in the endocrine field? Or maybe endocrinologists in Austin are better updated because you're there?
It's an interesting thing. We went around for so many years, as you know, telling people glucose, 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 lower the fasting, fix fasting first, start with basal insulin as first injectable. And then we kind of gravitated away. Now we have GLP-1s. I mean, the short answer is I think we're really starting people on GLP-1s first for injectable. That's what we're doing. And the American Diabetes Association agrees first injectable should be a GLP-1 med. And then, then you get into the question of what about, why just focus on glucose? And so I think we are increasingly, you're right, we're in a clinical practice here in Austin, and increasingly we're looking at cardiovascular risk as a reason to start not just glucose at all. I mean, the current recommendation is regardless of baseline A1C.